Welcome to the RatChat with Dr. Taylor Ratcliffe, putting the cheddar in your chatter.
Hey everybody, it's Dr. Taylor Ratcliffe here. We are at the Williamson County EMS headquarters, and we have got a great speaker today. We've got Dr. Sham from Texas Children's Hospital, and this is the RatChat. So I'm going to go with Jimmy Fallon, welcome, welcome, welcome. You're here. You made it. Thanks for coming in. So Jarvis did a lot of stuff in this office at this desk, but I think since I've been here, I think you're the first person that we've talked into coming in to sit down and do a podcast.
Well, thank you so much for having me. I really appreciate the invitation to come over to Wilco and be here with you.
So a lot of our team knows you already, but do you want to just introduce yourself to the audience and
I'd be
tell
happy
them
to do
what
so.
you've been up to lately?
So my name is Sham Sivashankar. I am one of the EM-trained PEM docs over at Texas Children's North Austin. I've been there since the hospital opened, and we've created this really great relationship with Wilco EMS, and we really appreciate the camaraderie that we've had, the ability to give and receive feedback on what's been going on, and also have this chance to really talk about some of the really interesting cases that have come in through the ER.
So we're really blessed. I mean, I think that all the transition kind of happened right as I came into the organization. We went from needing to take all of our critical pediatric patients really to downtown Austin. And now we have your facility. We have a couple of great facilities right in our backyard now. So it's been awesome to have you guys. We're super excited. So tell everybody, what's kind of the difference between why do you choose emergency medicine peds versus peds emergency medicine?
I had this experience when I was in med school where I felt being in the peds ER was kind of my home. And I really wanted to do peds at first. And I had an experience where I took care of some really sick inpatient kids, and I was like, man, I can't do this. This is really challenging. It was actually a peds hem-onc rotation.
Oh, okay.
Spoiler alert to what we might be talking about later today.
Little glimpse.
And I said, I really still want to be in the peds ER, but there has to be a different way to do this. And I got introduced to the world of emergency medicine through our mutual colleague, Dr. Marshall Isaacs at UT Southwestern. In Parkland, and I fell in love with the ER. I was like, man, this is such a cool place to learn to care for the spectrum of patients that you see and have a little bit more procedural autonomy and experience than going through the peds route. Both routes are great. I depend on my peds colleagues to tell me more developmental baby things, all those kinds of things, but having the facility with things like point of care ultrasound and procedures and things like that, it's just a blessing to go through the EM route.
Well, and that's one particular thing that I like about y'all's emergency department is there's a lot of you guys that are trained like that. And so you're very comfortable with the sick kids that we bring you, especially really sick ones like we're going to talk about. And then, if we happen to drop off an adult here and there, maybe they're with them, then nobody really freaks out.
Yeah, absolutely. And we have a labor and delivery unit, so we actually take care of, I think, almost a pregnant patient on a daily basis in our emergency department. So
Terrifying. No. Well, cool. What I think got this started was we were talking back and forth, and there were a couple of kids that had come in with a little bit of a unique diagnosis that I don't think we knew were lurking in our community. And I don't mean that in a bad way. That's lurking sounds bad, but residing, living, growing. And so when you and I talked, it was like, man, maybe we could do a little bit of a podcast about this, and then maybe also talk a little bit, not just about that disease process, but also what do we not know that kids have until they show up with it, right?
So what was really interesting is both these cases came within a span of, I think, 2 weeks of one another. And they're similar, but also a little different. So that's why it's going to be really great to talk through these cases. And both of these kids are infants. They're essentially under the age of 1. And we're going to start with the first case, delve a little bit into it, and then we'll move on to the second case, and then talk a little bit about these kind of de novo conditions that arise in pediatrics and when we should put our hats on a little bit and be like, hey, what are we missing? What should I also be thinking about?
I think for our providers, 0 to 1 is terrifying. 1 to 2 is generally terrifying, and more than 2 is maybe. maybe I'm okay.
Yeah.
I don't know. So, all right, great.
I mean, infants, 0 to 1 is always every single person you'll see, and you'll be like, that baby will fool you 100% of the time.
Yeah, they're tricky. They really are.
So the first case is a 2-month-old. He was brought into our emergency room from an urgent care. The urgent care called because this kid was notably hypoxic on room air, was kind of around 82 to 84%. Was brought into the urgent care because he's had 3 to 4 days of flu-like illness, not eating as much, kind of having some cough, congestion, and then today started having this more difficulty breathing. At the urgent care, he was tested for flu and COVID, and that was negative. RSV as well was negative, and was noted to be a little febrile. Got into our ER, and the pre-hospital team did a great job, started him on some blow by oxygen because he was not really tolerating much else. Got his O2 sats up to the mid-90s.
Now, did we move that kid from
Yes.
the urgent care to you?
Urgent care to us,
Okay,
yes.
okay, got it.
But, overall, this kid was pretty toxic, when they came in. And it's hard for us to throw that word around, right? It's not whenever we see someone toxic, we're saying this is a kid that is got something going on.
So in your world, I mean, that's an important word, right? So in your world, when you say toxic or lethargic, I mean, when you teach the residents, right, what do you key off on that says toxic or lethargic?
I think one big thing for me is when I'm messing with the kid and the kid doesn't mess back with me, that's when I'm like, whoa, this is not
mad.
normal.
Yeah.
You're not mad at me, right? When we're putting in an IV and you're not crying or you're not pulling back and you're not crying, you're not fighting me. That's usually what I tell parents. I was like, the fact that your kid is fighting me, that's good news. Right? When they're not fighting me, that's when I worry.
Yeah.
And so this kid was tachypnic, nasal flaring, using accessory muscle, had some pallor to him, was, having what looked like a distended abdomen. Cap refill was a little delayed, like 2 to 3 seconds. Respiratory rate was about 72, so breathing quite fast.
Okay.
Obviously was febrile. Heart rate was in the 190s. So
just for our audience, real quick, normal for this age group should
Yeah.
be respirations of around
going to be 40 to 60, kind of depending on the age, right? This is a 2-month-old, so up to probably 50 to 60 is normal.
Okay.
So we're already past that 60 mark. But usually 40 to 60 is going to be within the first 6 months. And heart rate, whenever we start seeing a heart rate over 160 as well, that's when we're like, hey, what else is going on? Are we missing something?
Sure. Okay.
And this kid, interestingly, this is something that we're going to see in both cases, was profoundly hypoglycemic. Your team noticed that his blood sugar was less than 20.
Wild.
Yeah.
Yeah.
So
that's really bad.
That's low. Yeah. So that's pretty scary. So they did the right thing. They gave some sugar. They gave sugar again. And when he got to our ED, we started him on a maintenance strip of some glucose-containing fluids.
So I can't remember. What did we do for access in that kid?
This kid actually had access. This kid had an IV.
A peripheral IV.
A peripheral IV.
Great. Yeah.
So that was awesome for your team as well.
Yeah. No, that's super good. Kudos to whoever started that.
Yeah.
That's good.
Second case had an IO, but we'll get to that.
Okay.
What was really interesting is your team also noticed that there was some bruising around this patient's abdomen. And it was one thing, it's like his belly looks really big and it's a little discolored. And our ED doc, who happened to be on that day, is a triple boarded EM, IM, PEDS doc.
Oh.
He did med PEDS and then did an EM
That's all?
residency. Yeah, just
Okay.
like, so he looked at it and goes, that's Cullen's sign. And I was like, man, I haven't heard a Cullen sign in a long time. So I said, let me talk a little bit about this, which is a really interesting physical exam finding where there's discoloration or kind of bruising around the umbilicus.
Mm-hmm.
And what you tend to see this is with abdominal catastrophes, right?
Right.
You tend to see it with some sort of surgical emergency, some sort of hemorrhage in the abdomen. You can occasionally see it with cancers, malignancies, and other weird coagulopathies. And then because of this distension, the next thought was, let's decompress him a little bit.
Sure.
So put down an NG tube. What do we get? Coffee ground emesis. So we're like, oh man, is this kid having a GI bleed now? And so,
Yeah, so when we say coffee ground, we're thinking about digested blood, right? That's
Yes.
been processed with stomach acid, and when it comes back up, if
Yeah.
you've never seen it, it looks kind of like coffee ground.
yeah, so you'll see this more commonly with adults. Coffee ground emesis is not a common thing that we see in kids. When we see that, we're like, oh boy, there's more going on.
Sure.
So initially, we also said this kid was on some blow-by oxygen. We had transitioned him over to high-flow nasal cannula.
Okay.
And at this point, we were like, okay, how much respiratory support does this kid need, right? That's always the question. And you kind of, in the ED, we have a little bit more resources at our disposal. And one of the things that we like looking at is tracking serial blood gases. And so we put the kid on high flow, and his pH, after being on high flow for about 30 or so minutes, dropped. So went from a pH of 7.1, which is already pretty low, to 7.0.
And we'll just remind our audience, right? So normal is 7.35 to 7.45. And I feel like the scale seems backwards for some reason. Higher is more alkalotic or basic,
Correct.
right? And then lower is more acidotic.
Yes, so this kid is quite acidotic.
Yeah, not good, right?
So at that point, we said, okay, we got to intubate this kid as well.
Okay.
And then, of course, volume resuscitation, right? We've got a febrile kid that's quite ill-appearing. This is septic shock until proven otherwise.
Sure.
Right? So this is aggressive IV fluid resuscitation, broad-spectrum antibiotics, and after 3 boluses of 20 per kilo cc's, which is kind of the max that we start thinking about with pediatric fluid resuscitation as far as crystalloids go, what's the next step after that is like thinking of something like pressors and adding on something like stress dose steroids,
Right.
which is what we did in this case.
So were y'all already thinking about some of these undiagnosed congenital conditions and things like that? I'm
Absolutely, yeah. So inborn errors of metabolism
Right.
is huge in this age range, right? So a 2-month-old is something missed on a newborn screen, and then let's compound that with the fact that this is a family that does not speak English.
Sure.
Okay, so that also adds an additional barrier to communication, right? And so, hey, what has been done? And when you're trying to explain like newborn screen through like a bunch of people trying to resuscitate
Interpreters
this,
and all these
this
things,
child, and you have a video interpreter, like a lot of things, you don't fully obtain the entire history right away in the emergency department. Just like when you go on a scene, right? You don't have all the answers.
And Sean, real quick, I know we're going to get into it. When you say newborn screen, a lot of our parents know what that is. But
Yeah.
like, what are we these days? What are we looking for? Like, what can we screen for?
Yeah, so newborn screens look for a lot of different things. The majority of these look for metabolic disorders, things that if we can add a medicine or a dietary change to your regimen, it can actually transform the life of
Wait,
this
can I
newborn.
say a word?
Yes.
Phenylketonuria?
PKU.
Is that right?
Yes,
Is that one?
yes, that is one.
Golly, thank goodness.
Yeah,
Okay.
but it also screens for other things like sickle cell disease.
Right.
It does screen for. It doesn't. Not every state screens for hemophilia, but some do. So there's other blood disorders in addition to metabolic disorders that these things screen for.
But there's probably still a host of things that we can't screen for that
That's
just
correct.
kind of have to show up.
Exactly. So
okay.
genetic predispositions to things, family histories of things, that usually goes alongside kind of outpatient studies.
Got it. All right, I keep derailing the story. I'm
No
sorry.
worries.
So
So
this kid's intubated now, still really sick, volume resuscitation.
yeah. So the next thing we start looking at is what sort of imaging do we need? Hey, we always should be at the back of your mind whenever you're seeing a sick kid is, am I missing something like a non-accidental trauma case as well,
Yeah,
right?
right.
We're seeing this bruising around the abdomen. He's vomiting blood. Like, is this some sort of trauma that
Yeah.
we're seeing that we don't want to miss?
It's sad that that's part of the world, but I mean, that's always...
Always at the back of our mind.
Yeah.
So we got some imaging, a CT head that was normal,
Okay.
a CT abdomen and pelvis, which actually showed a pretty big spleen and some ascites. And ascites is kind of that fluid that your liver is not able to process, and it ends up staying in the abdomen.
In an adult, we might see that in a cirrhotic or something like
Exactly.
that. But, okay.
Unusual in a 2-month-old.
Kids shouldn't have that.
No, they
Yeah.
shouldn't, right? So in addition, I think we have already talked a little bit about the things that we've done. We've given some fluid, we've given some antibiotics, we've started some steroids, we've started a PPI or a proton pump inhibitor for the GI bleed. That's kind of the mainstay of treatment for any sort of suspected GI bleed, even
Protect
in
the
adults,
stomach.
to protect the stomach. And then we started looking at these labs. His lactate was through the roof. It was like 14
Yeah.
in a 2-month-old.
Yeah. Normal should be 1.
Yeah.
Right.
So that's pretty high. We've already said he's pretty acidotic, and we've noticed that in his hematology profile, his hemoglobin is down, his white blood cell counts are low, his platelets are low. So we start
Okay.
kind of giving back some of those. We give some platelets, some FFP, and some vitamin K. And then we've started this broad infectious workup, but some other numbers don't look right. His liver function is really elevated as well. And it's at this point when we start thinking, hey, this could be septic shock. but what else could look this dramatic, right? This kid has only been sick for 2 to 3 days. Right. And of course, septic shock could look like this, but this is when we also have to make sure we're not missing anything else. And this word gets thrown around, which is the diagnosis that we're going to talk about today. And it's something called HLH.
Okay.
And HLH is this word, it's like this
Throw it out
abbreviation that we use, right? And it's hemophagocytic lymphohistiocytosis. That's why we say HLH.
Yeah, clearly, yeah. I don't think I can type or spell that.
Yeah.
Probably.
So it's this really rare, life-threatening, immune-mediated phenomenon. So what ends up happening is our immune system, instead of just kind of doing its job, kind of goes on overdrive. It just kind of like says, I'm just going to ramp everything up.
Sure.
And instead of just fighting the infection, it kind of starts attacking our body's own tissues. It's an autoimmune. It's like an acute autoimmune disease in a way. And even if you have an autoimmune disorder, you can actually get this. And we'll talk a little bit about the other types of what can cause HLH in a second. But
so we're attacking body systems like the organs, like the spleen, like the blood production system in the body. I mean, all these things that can affect.
Yes. Okay. So the bone marrow primarily, and right. So the bone marrow is the precursor for white cells, for red cells, for platelets. So we start to see all those levels start to dip. And the test that we like using is something called a ferritin level, okay, which is a acute phase reactant, and that usually shoots up in HLH. That's our first clue. And this kid's ferritin was really elevated. Okay. There is a set of diagnostic criteria. It'll be on the slides, but these diagnostic criteria, you have to meet 5 of them for a diagnosis of HLH to be considered. And this kid ended up meeting these criteria. He had fever, splenomegaly, which we saw in that CT scan, cytopenias. By that we mean low white cells or low red cells or low platelets, and you have to have all, and you have to have 2 of those 3 lines down. Okay. You can have elevated triglyceride levels or low fibrinogen, and elevated ferritin levels. So those were kind of the criteria that this kid met.
Okay.
The RatChat, featuring Dr. Taylor Ratcliffe, brought to you by Knipstein Queso, cutting the cheese one slice at a time.
Let's now explore what can cause HLH.
Sure.
And when we think about HLH, it can be primary. And by that I mean there is a genetic component to it.
Okay.
It is an inherited condition on something that something goes wrong with the immune system. There's a checkpoint.
Coding is wrong. Yeah.
The checkpoint is not being met.
Okay. And I'm not putting you on the spot, but how common is that?
It's super uncommon. It's
I don't know.
Yeah, I don't know the numbers exactly off the top of my head, but the genetic subtype is usually only found in infants.
Okay.
So someone like this child.
So it's in the very, very rare bucket.
Very, very rare bucket.
Got it. Okay.
And the more common type is actually the secondary type. And this is triggered by something else. And this is triggered by infections, malignancies, and occasionally autoimmune diseases can kind of trigger their own acute autoimmune phenomenon. And that is known as macrophage activation syndrome, or MAS.
Okay.
We see this in lupus patients, JIA patients often.
And so their underlying inflammatory condition finally causes this widespread response in the body.
Yeah, exactly.
You know, it was interesting. You said, and we might just talk about it for 2 seconds. You said checkpoint. It's interesting. The body has checkpoints, right? Do you want to talk about that for just 2 seconds about why?
Yeah. So, I mean, our body needs to be in check. So it's kind of like a system of checks and balances, essentially, right? We go through these checkpoints in order to make sure we're not being over-aggressive, but we also want to make sure we're not being under-aggressive. So these checkpoints kind of loop back. They have this feedback loop. It's almost like the way our endocrine system works.
Right.
Hormones. Our immune system is the same way. It has these fundamental little check boxes that says, hey, how are we doing with fighting this? Oh, we're good, so we can tone this part back down. Mm-hmm. And in HLH, that trigger is not there. It's not like, hey, we're good. We don't need you anymore to continue fighting. And it just doesn't, that feedback loop is disrupted in some way. And so it just keeps plodding forward. The secondary form of HLH is actually more common in adults.
Okay. So adults can have this too?
Absolutely, yeah. Okay. But the genetic form is really only seen in young children.
I don't think I knew that adults could get this.
Yeah, I learned
interesting.
about that too.
Okay. All right. I have to remember that.
Yeah.
I'll sound really smart with the residents if I try and diagnose this. They're going to be like, "Wow, Ratcliffe really knows stuff."
Yeah.
Yeah.
So we're gonna put a pause on case 1 right now.
Okay.
So what we've got so far is this really sick kid that came in with flu-like symptoms, noted to be in what looks like a septic shock state, but the labs say, hey, maybe it's more than septic shock.
Right.
It's this HLH phenomenon.
Right.
So we're gonna put a pin in that case for right now.
Okay. And this kid at this point is admitted in the PICU.
Yes.
And
In the PICU, is on support.
we've got big brains thinking about this. And
then we'll address kind of the thought process on how exactly we deal with someone like someone with HLH.
Sure.
The RatChat is sponsored by The Boring Company. We put the holes in your Swiss cheese.